Hello, welcome everybody to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the U.S. Centers of Disease Control and Prevention, also known as the CDC. I'm Dr. Tariq Ahmad, and I'm a professor of pediatrics at the Division of Pediatric Endocrinology at UCSF Benioff, Children's Hospital, Oakland in California. I'm delighted to be here to moderate and take a deeper dive into the role of transfusion-related endocrinopathies and thalassemia. But before I introduce our guest speaker, a few points for joining this webinar. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and audio PIN. All audio will be muted. At the end of the presentation, there will be time for questions. And to submit a written question, please use the questions area of your toolbar. The speaker will try to respond to as many questions as time allows. Today's webinar will last approximately 1 hour, and please note that it will be recorded. To start this webinar, we have two brief audience polls that we would like to survey. First, to know more about you, please select your response to the poll question now. So hopefully everybody was able to submit an answer to the poll there. And it appears that we have a fair number of healthcare providers, though all the healthcare industries have been represented here, including the community-based organizations and public health professionals. The second online question or poll question is to designate the region from which you live. So we can get some geographic distribution, an idea there. So please submit your answer now. All right, so let's see where everybody answered from these 5 areas, these geographic distributions. So we're probably still waiting for Australia and South America to log in, but we have a fair number from North America. And I'm welcoming those from Europe and Asia or Africa who are joining us on this webinar. So it's my pleasure to introduce today's speaker, Dr. Ayca Erkin-Cakmak, who is an assistant professor of pediatrics in the Division of Pediatric Endocrinology at the University of California, San Francisco. Welcome, Dr. Erkin-Cakmak. With that, let's begin.
Thank you for the warm welcome and kind introduction, Dr. Ahmad. I also would like to thank you to Cooleysanemia Foundation and CDC's Division of Blood Disorders for hosting this webinar and creating an opportunity to share our experience and thoughts on growth in endocrinopathies in patients with thalassemia. Thalassemia is a near and dear disease to my heart as well, since I'm coming from a Mediterranean country where we do have so many friends and family with this disorder as well. As we all know, thalassemia is a heterogeneous group of inherited anemia caused by reduced or absent synthesis of either alpha or beta globulin chains, and most common form of inherited anemia worldwide that may require regular blood transfusions and lifelong medical care. And regular blood transfusions are the predominant cause of iron overload, along with enhanced gastrointestinal absorption. When we look at the epidemiology of thalassemia, as you can see, it's endemic in the Mediterranean region, Africa, the Middle East, Indian subcontinent, and Far East. And why do we need to learn about thalassemia is because you're looking at an immigration data from 2019 here in the slide. And as you can see, there is a great percentage of people immigrating from Asia to United States. And by Asia in this graph, it is representing China, India, and other countries in South Asia. Asia is the leading source of immigrants in California as well. And this chronic disease is the challenge of immigrant population, which is already challenged by accessing the healthcare, the language barriers, and navigating the complex healthcare system here. In this slide, we are seeing the natural history of untransfused beta thalassemia major. And as you can see, during the early months of the life, all these patients are asymptomatic infants, but after 6 months of life with ineffective erythropoiesis and peripheral hemolysis, abnormal globulin chains precipitate in erythroid precursors and mature erythrocytes, resulting in ineffective erythropoiesis, marrow hyperplasia, hepatosplenomegaly, tissue hypoxia, failure to thrive, eventual bone deformities, congestive heart failure, and unfortunately, the mortality. And this was the natural course before we were able to transfuse and use the other modalities to address the thalassemia. With regular transfusions, we are able to correct and suppress the ineffective erythropoiesis, and with increased iron burden, but however, this caused increased iron burden, and excess free iron can undergo redox cycling and subsequently generate free radicals, causing cell dysfunction, cytotoxicity, and cell death. Introduction of oral chelators and imaging methods to monitor iron overload transferred the thalassemia from a rapidly fatal disease of childhood to a chronic illness that is compatible with prolonged life expectancy. However, iron overload still continues to be a significant challenge impacting the transfusion-dependent patient's quality of life, despite the substantial advances in management of iron overload. Here, if we summarize, anemia requires regular blood transfusions. Blood transfusions cause iron overload and then excessive oxidative stress, causing liver disease and endocrinopathies. Here we are looking at a table derived from Thalassemia News back in 2001. And as you can see, there are this table represents the endocrinopathies reported in different parts of the world. And as you can notice here, hypogonadism and short stature are the most commonly reported endocrinopathies around the world for patients with thalassemia. Again, this is another another visual that is recreated by the data published by the scientists et al. In 2004 and the Thalassemia International Federation guidelines in 2021. And in this graph, we are looking at a multicenter study results of endocrinopathies in thalassemia major patients. And the number of patients evaluated in this study or publication was almost 4,000. And again, strikingly, hypogonadism and short stature are the most commonly reported endocrinopathies, followed by glycemic abnormalities, hypoparathyroidism, and hypothyroidism. I also would like to mention you our experience here in San Francisco. We did an observational study to describe the patient characteristics and prevalence of endocrinopathies in transfusion-dependent thalassemia patients cared at the Northern California Comprehensive Thalassemia Center between January 2000 and July 2021. And we utilized the clinical management data registry associated with the Department of Hematology here at UCSF. And here is a brief table to summarize the characteristics of our participants. We had 253 eligible participants, meaning that they were transfusion dependent, older than 7 years old, who did not have bone marrow transplantation, who didn't have transfusion dependence due to other types of anemia, such as Diamond-Blackfan. We did have equal representation of both males and females. And very strikingly, we do have a very big patient population who are actually adopted mainly from China. 1/5 of our patients were adopted. The median follow-up time was 10 years, and the median ferritin level was 1900 in our patient population. And we do have a very diverse patient population here, as you can see. around, given that California is receiving a lot of immigrant population around the world. And majority of our patients had the diagnosis of thalassemia major, the 69% of them. We do so that 50% of our patients have at least one endocrinopathy. And over here, you're looking at the scatter plot of the number of endocrinopathies on the y-axis and the current age of our patients on the x-axis. And as you can see, there has been a positive correlation between the number of endocrinopathies and the current age of our patients. When we try to understand whether there is a association between or correlation between the serum ferritin levels and the number of endocrinopathies, we couldn't find a significant correlation, but we were looking at our patients with a cross-sectional manner, not longitudinal, and looking at in a longitudinal manner to understand whether the serum ferritin levels over time would be impacting the number of endocrinopathies. Over here, you are looking at the prevalence of short stature in our patient population. We did have growth data on 184 patients that are available to analyze, and the median height, final adult height for a female patient was 109.5 centimeters. For a male, it is 167.5 centimeters. And as you can see here, the median final adult Z-score was -0.5 for females and -1.3 for males. The final adult height was more compromised in males compared to females. And we did have 84 growing patients, which we evaluated for growth hormone treatment needs, and 14 of them were able to receive growth hormone treatment. Hypogonadotropic hypogonadism was observed in 1/3 of our patients, and it was almost equally distributed between males and females. And when we look at the bone health, again, the mean bone mineral density Z-score for spine in our female patients was -2.1. For males, it was -2.5. And height adjusted Z-scores less than 2 was observed in 43 and 49, 1/3 of our patients for both genders. Since we are focusing on growth in this webinar, I wanted to have a couple slides about the normal growth. As we all know, normal growth is not continuously linear, and it is important to assess its progression over a longer period of time. And here we are seeing a linear growth velocity in boys and girls modified from Tanner et al., which is a very important parameter to monitor with certain intervals, at least 4 months, to assess the growth patterns. And as you notice here, there's an initial fast growth velocity, followed by slowing during the early childhood years, and again with increased growth velocity during the times of puberty, slightly earlier for girls and then later for boys, based on the timing of the puberty. We describe the short stature as height less than -2 standard deviation for age and sex, and height more than 2 standard deviation or 4 inches below the mid-parental target height. So when we think about the growth deficits in thalassemia, there is a recent publication from last year by Arab Zozani et al., and they did a systematic review and meta-analysis of short stature in patients with beta thalassemia. And they reported the pooled prevalence of short stature as 48%, and the prevalence was higher in males compared to females. And when they look at the growth retardation, they reported the pooled prevalence as 41% as well. Again, the males were more affected compared to females. The pooled prevalence of growth hormone deficiency was also reported in their meta-analysis as 26%. The impaired growth in thalassemia is, when we think about impaired growth in thalassemia, we need to think about the childhood in different phases. Throughout the childhood, there are different reasons for the alteration of growth in children with thalassemia, as it is pointed out in the Annals New York Academy of Science. The first phase of childhood is the first 5 years of life, and the growth is impacted by the hypoxia, nutritional factors, and anemia affecting the growth hormone IGF axis. And in the past, this type of growth disturbance was more common, and it still remains a concern, especially in children with thalassemia intermedia who are being monitored to decide if they should be placed on chronic transfusions or not. And the second phase of childhood is the before puberty, between age 5 to 10 years. Anemia and iron load affecting growth hormone and IGF axis is the main problem here. And the third and last phase of childhood is the peripubertal years, between age 10 to 12. The growth and the pubertal spurt are both affected with disturbances in puberty. The third phase, where the hypothalamo-pituitary gonadal axis is mainly affected due to iron overload. And this is the commonest type of impaired growth pattern in current years. There are also multiple other papers that disseminated the information about the impaired growth in thalassemia, and they reported hypermetabolism, chronic anemia, hypoxemia, especially in undertreated children, the position of iron in endocrine organs, such as thyroid, gonads, pituitary, and adrenal glands, nutritional deficiencies such as zinc and folic acid, liver disease, defects in secretion of gonadotropins, emotional factors, and deferoxamine-induced bone dysplasia are some of the suggested mechanisms in the literature. We also see in adolescents the disproportional truncal shortening due to flatus spondyli, and this results due to iron overload, deferoxamine toxicity, deficiency of trace elements. Growth hormone resistance is also another mechanism, and low serum IGF-1 and IGF-BP3 concentration speaks to the growth hormone resistance. And impaired pubertal growth spurt is another mechanism that we mentioned briefly. And there are papers out there reporting the growth hormone therapy resulted in significant improvement in growth velocity in short thalassemia major patients without any adverse effects on skeletal maturation, blood pressure, and glucose tolerance, but it is very small number and from very early years. And when you look at the ferritin levels, ferritin levels, here we are looking at a study from Malaysia done by Hamida et al. And they look at growth velocity in 26 prepubertal transfusion-dependent patients with beta thalassemia major and hemoglobin E beta thalassemia. And their patients were all in the younger side, age between 2 and 13 years. And what they reported in their study, the prevalence of impaired growth velocity was 57.7%, and they described or defined the impaired growth velocity as growth velocity that is less than 3rd percentile. They reported a mean serum ferritin level that's higher in patients below the 3rd percentile for height. And in another study from 2005, and this is a retrospective study from Israel, looking at the patients' data between 1987 and 2002, 39 patients with median age of 17 years were evaluated, and this group reported a mean serum ferritin level that is significantly higher in patients with a final short stature than in those with a final height of more than -2 standard deviation. And the mean serum ferritin levels, when they look at the mean serum ferritin levels with before and after puberty, the prepubertal years, the serum ferritin levels were significantly higher in patients with short stature as an adult compared to those with a final adult height that is more than -2 standard deviation. Mean ferritin levels of 3,000 nanogram per milliliter in the prepubertal years was reported as a cutoff for the final short stature in this study. And we know when we think about the nutrition and effect of nutrition on growth, we know anemia contributes to poor appetite, and the slower rate of growth may also be related to higher rates of energy expenditure or a low hemoglobin level in the days prior to scheduled transfusions. But overall energy expenditure shouldn't be being a significant concerning factor impacting the growth, given the patients with thalassemia also has a reduced physical activity patterns. The relationship between the zinc deficiency and growth deficits is reported widely in the literature, and in the study, Arjasoy et al. Did a zinc supplementation in 32 growth deficient transfusion-dependent thalassemia patients aging between 1 to 18 years of age, and they followed up these patients up to 7 years. And what they reported in their publication, those provided zinc had a greater growth velocity as compared to the control group. As you can see, this is a very old study from 1987, but then in 2009, we had another group who looked at the effects of zinc supplementation on growth velocity in 22 patients with biochemical evidence of zinc deficiency, and the mean height velocity of zinc supplemented children was significantly higher compared to the controls. And another new study from 2013, which was done with Fang et al., the Think-Zinc study. Actually, in this is a double-blind randomized placebo-controlled trial that was completed with 42 transfusion-dependent thalassemia patients, where they randomly assigned to receive either zinc supplementation or placebo. And the objective of this study is to look at the effect of zinc supplementation on bone mass in patients with thalassemia. And what they saw as a secondary outcome, the IGF was notably increased in response to 25 milligrams zinc supplement versus placebo in adolescents with thalassemia patients. Of course, growth hormone. This is a very old study that I was able to find looking at the effect of growth hormone and thalassemia, but I think it is still very valuable to understand the challenges around growth hormone. In the study, they look at the response of growth hormone, response of growth hormone to administration of growth hormone releasing hormone, and 19 thalassemia patients and age matched 8 healthy children was evaluated. And as you can see here, the open circles are representing the thalassemia patients, and then the closed circle is representing the normal subjects. And normal subjects has a much higher peak growth hormone level early in the administration of the growth hormone releasing hormone, and 13 of the 19 patients with thalassemia who received the growth hormone releasing hormone has an increase in their growth hormone secretion during the during the first 5 to 45 minutes of injection, and the peak was much lower compared to normal subjects. And in 6 patients, there was little or no growth hormone rise after the growth hormone releasing hormone administration. And this study means the mean growth hormone response to growth hormone releasing hormone was lower in patients with thalassemia than that of normal children. And this is another study that was performed by the scientists in 2000 and published in 2011. They did perform growth hormone stimulation test using the arginine and growth hormone releasing hormone, and they enrolled 32 adult thalassemia patients, and the mean age was 36.6 years. And the baseline IGF-1 levels were consistently low in this patient population. Following the growth hormone stimulation test with 2 different agents, they observed 42% of their patients had severe growth hormone deficiency, and the severe growth hormone deficiency is described as the peak growth hormone below 3 milligram per deciliter. And there's also a normal growth hormone response to growth hormone stimulation test in 86.6% of the patients, where they also have a low IGF-1 level. And these findings speaks to the relative resistance to growth hormone. They were able to report a positive correlation between the growth hormone peak after the growth hormone stimulation test and the IGF-1 levels. And they also reported a negative correlation between the age of the female patients and the growth hormone peak. A few words about the hypogonadism and thalassemia, since puberty is an important factor that is affecting the growth. And this is a table from a review that is published by the scientists et al. In 2018. It's a busy table, but the main point over here is these 4 papers summarized in this table are actually representing the data around the world. And in the study from Malaysia, the number of patients in the study was 25, a small n, and the patients are mainly young adults, and the prevalence of the hypogonadism was about 40% and equal in both males and females. In the second study that is published from United States, the number of patients in this study was higher, about 361. And the main finding is for patients who are older than 20 years in this study or in this publication, the older patient population had hypogonadism, and it was more prominent. In males. In the third study from Egypt, 100 transfusion-dependent beta thalassemia patients who are older than 10 years were enrolled. And in this study, the prevalence of hypogonadism is noted as 59.1% in patients who are younger than 14 years. And this makes me think whether the delayed puberty is captured with this study. And lastly, the scientists performed a study in Italy in 2016, and they had 43 transfusion-dependent beta thalassemia patients who are older adults, and they reported a higher prevalence of hypogonadism in the males. As a conclusion, I think it is fair to say endocrinopathies continue to be a common sequel of transfusion-dependent thalassemia, and growth deficits are common in patients with thalassemia and continue to be a significant morbidity in transfusion-dependent thalassemia patients, despite the improved chelation agent availability and tissue iron monitoring. And the etiology is multifactorial, as we all reviewed. The future directions, we should focus on the role of growth hormone treatment to improve the growth velocity in children, the final adult height, and the bone mineral density. And we should think about the role of growth hormone in adults to improve the bone health. And ask the question whether we can utilize the insulin-like growth factor to support the growth and bone health, given that we have evidence of growth hormone resistance in patients with thalassemia. This is the screening guidelines from 2012 that we utilize in our clinic setting. So we are monitoring the growth and development periodically to assess the growth velocity and the pubertal initiation. And then we do assess the bone health with DEXA scans starting from age 10. And we do monitor for endocrinopathies starting from age 5 periodically. And we, this is the screening guidelines that we have in place, but we definitely need further longitudinal studies to understand the endocrinopathies better, so we can update our screening guidelines and be a better help to our patients with thalassemia. Thank you so much for your attention, and I'm happy to take any questions.
Well, thank you so much, Dr. Erkin-Cakmak, for this excellent presentation and review of the literature. We're shifting now to the question and answer segment of the webinar. Again, just to remind everybody, you can submit these written questions using the questions area of the toolbar. And I know a couple questions had come in already. You adeptly answered one of the questions, which was to summarize some of the key tests we should ask the endocrinologist to run and at what frequency with that last table. So that's much appreciated, and hopefully people will be reminded that this presentation will be archived so you can access that table at any time. I think one point that I would make too, as Dr. Ayca Erkin-Cakmak mentioned, is that this is an evolving medicine in so many ways. For instance, we are also learning more and more about the adrenal axis and how to screen and when to screen for the ACTH cortisol axis in these individuals, as we're finding that a fair number of them are actually becoming deficient, even if not in their youth, as they age, that can become an issue. And it's important to be aware of that particular endocrinopathy as well. So one of the questions I might ask you, which is interesting too, is why do you think the hypogonadism is more prominent in males? I guess this was in reference to slide 33, if you had some thoughts.
Yeah, so I think one of the reasons that study reported a higher hypogonadism in males is because they were done in the earlier years, and then also the age of the patients were much older. So we know that over the course of last decade, we have better chelation. So we are able to control the iron toxicity slightly better compared to teenage years or early years of current adults. So I think one of the reasons that they were reporting higher hypogonadism overall in older patient population is the availability and access to the chelation. And for the males, I'm not sure how to approach that. And the hypogonadism, when we think about the hypogonadism mechanism, the the hypogonadotropic hypogonadism is much more prominent, so the accumulation of iron in the pituitary gland would be the problem rather than the testicular accumulation of iron. So I would appreciate if you have any insights or thoughts on that.
Being male, I have to always wonder if the males are just not as good as chelating as the females may be. But there's so many avenues and mechanisms along the pathway of the gonadotropin gonadal axis that can be affected, and then it begs the question, are particular cells then more vulnerable perhaps to iron toxicity? And because one thing I noticed was, for instance, the shorter stature in males, right, compared to females. And one can argue perhaps that, again, because they're hypogonadal, particularly in males, then you're losing the androgen growth hormone synergy that often comes across in the pubertal growth spurt, which would be much more important in males, for instance, than females. And that's perhaps why they have a greater effect on their ultimate end adult height compared to females.
Yeah, that makes sense. And also, if you think about the follicle development and ovulation in females, every month there's a set of dormant follicles that are developing. So the follicles who are not in the cycle or developing might be protected from the effect of ferritin or iron toxicity as well.
There was a question here, which is a good one, that I see fasting glucose was on the last table that you mentioned. Should it be fructosamine instead, since these individuals are transfused? Maybe I can get your answer and share your approach to how we monitor for glucose intolerance or issues that's going along the glucose pathway.
Yeah, so that's an excellent question. Definitely, these thalassemia patients are at risk for glycemic abnormalities, and it's kind of challenging to look at the fasting glucose. They are transfusion dependent, and we know because of the hemolysis and the transfusions, we cannot rely on the hemoglobin A1C for screening. So what we are doing actually in our clinic setting is quarterly we are checking the fructosamine levels to assess the glycemic control or the pattern of glycemia over time. And right now, actually, we are in our own data, we are trying to understand the correlation between the quarterly fructosamine levels and the findings that we see in oral glucose tolerance tests that we do every other year, starting from puberty, from the time that we know the insulin resistance increases. So I think it will be definitely interesting to see what we will be finding, but utilizing the fructosamine and thinking about oral glucose tolerance test periodically in the teen years to monitor the glycemic control is important.
Yeah, thanks. Again, to underscore, I think what you're saying, what you said, was that fructosamine wouldn't be used as a diagnostic tool, but again as a potential screen. But like you said, the OGTT or the oral glucose tolerance test would be the best way. It's just, as everyone knows, it's a very cumbersome test, and not everybody is able to sit for the 2.5 hours to do the oral glucose tolerance test. And while fasting glucose may be another option, please keep in mind it's not the best test, right? Because like a stress test for an EKG, you may not really elicit any issues until you stress the pancreas with a glucose load. So the fasting glucose can be sometimes deceiving. There was a question. Let's go ahead.
May I add one more thing about the oral glucose tolerance test? Yes, it is very cumbersome to do, but actually we have these patients periodically coming in for scheduled transfusions every 3 to 4 weeks, and they spend a few hours in the transfusion for the transfusions. So what we have been doing is we are trying to coordinate the stimulation test or oral glucose tolerance test while they're already in the transfusion center and getting their transfusions. So we are trying to maximize the time they spend for transfusions, but also getting all the screenings done.
Thank you. Yes. Going back to the gonadotropin axis, there was a question here on how can you tell if male infertility is due to pituitary failure versus testicular failure? And then
Yeah.
how would you treat the male infertility?
That's a good question. So for the infertility, if you do see the low gonadotropins along with low sex steroids, the testosterone or estrogen, I would be more worried about hypogonadotropic hypogonadism that's originating from the pituitary. But if you do see high gonadotropin levels and pituitary is trying to stimulate the gonads, but there's no response from ovaries or testicles with the estrogen or testosterone production, then the gonadotropins will be higher and the problem will be mostly gonadal and gonadal toxicity rather than the pituitary being affected by the iron toxicity. Regarding the treatment, I would defer it to our infertility specialist at this time. I don't think that I will have a good answer for this question.
Yeah, I mean, just using, I would think from our population, non-thalassemia, who have hypogonadotropic hypogonadism, the key takeaway is that hopefully that the testes still work, even though the pituitary may not, so that there are ways to provide gonadotropins to foster spermatogenesis. The tricky thing, of course, with thalassemia is that not only can you get central pathology, but rather end organ pathology. So it's actually possible to have both hypogonadotropic hypogonadism, but still have primary testicular failure. And so there is both sides of the pathway that you have to analyze and make sure that they're both okay. And certainly the fertility specialist will be your best individual or best group of individuals to deal with that. Going to probably the most common issue that occurs in adults with thalassemia, there's a lot of questions on bone. So hypogonadism being one of them, but bone certainly is a big issue in our adults with thalassemia. One question that jumps out at me here is, what do you think about the use of bisphosphonates and denosumab in adults? And is DEXA an adequate tool to assess bone health?
I think so. I think there are a couple parts to this question. Definitely, the bone health is a major concern both for growing patients but also the adults. And the best, and we need so many longitudinal studies to ask so many questions about bone health in both adults and children. Regarding assessing the bone health, the DEXA is your best tool to, and also I think there's a utility of high resolution PC bone scan to look at the bone. Yes, thank you, Dr. Ahmad, to look at the structure of the bone, not only the bone mineral density. The use of the denosumab and biphosphonates, I think it might be considered in selected patients, but the pros and cons should be discussed with patients, because we know that they have very fragile bones and low bone mineral density. So using the biphosphonates and denosumab can only patch the problem rather than really improving the overall health of the bone. What do you think, Tariq?
Yeah, no, what I tried to promote even in those, again, without thalassemia, is emphasizing to everybody, all our healthcare providers out there, that bone health is the result of what we do in our youth. And so we have to really start at a young age to focus on bone health, appropriate calcium intake, as well as vitamin D intake, because by the time you're 18 years old, you've already formed 90% of your skeleton already. Mm-hmm. And of course, by the time you're 25, 30 years old, you can no longer build any more skeleton. So whatever bone you put into the so-called bone bank, there's no more deposits that you can make. You can only withdraw. And if you're entering adulthood with a low repository of bone, then you're going to be even more susceptible to the bone issues, osteoporosis, etc., which means that now we're really talking more about what is the role of bisphosphonates and denosumab. In the pediatric population, again, as Dr. Ayca Erkin-Cakmak had pointed out, there's not as much review of the literature or studies been done in the kids. So we have to balance, the pros and cons. But certainly, if the DEXA scans are low, and we've maximized and optimized nutrition, it is something to be looked at, particularly because of the bone pain that can occur along with the low bone density, even in the youth. But yeah, I can only say that we have to start young, and we have to encourage and make sure that we look at calcium and vitamin D levels even in young childhood to make sure we're optimizing at least that aspect of bone health. Because as you know, bone health comes from so many different factors, not just nutrition, not just the chelating agents that may also be toxic to the bones, but also the exercise, for instance, and weight-bearing exercise. And we know from studies that we've done in here at Children's Hospital that as a whole, unfortunately, thalassemia patients tend to be not as active as they should be. And maybe that's a result of the pandemic or other things. But when we even did these studies prior to the pandemic, we noted that they were more sedentary. So weight-bearing exercises, nutrition, of course, making sure they don't have any endocrinopathies. Dr. Erkin-Cakmak already mentioned how growth hormone is an important role for bone density improvement. Of course, thyroid hormone, and of course, the sex steroids. Testosterone and estrogen are super important.
And we also know from the healthy children, the studies performed in healthy children, the physical activity, especially during the pre-pubertal years, contributes a lot to the bone structure and bone health. So I think encouraging our children with thalassemia to be more active and participate in physical activities and sports might also help them build stronger bone banks, as you described, to serve them better in their adulthood years.
Yeah, and speaking of bone health, and someone had mentioned this as a comment more than a question, but it's not just vitamin D, but there's other micronutrients and nutrients that we need to focus on. Zinc was mentioned already, magnesium, vitamin K, vitamin A, vitamin D, and as most probably comprehensive thalassemia centers have, there is a nutritionist that's going to be involved, getting a dietary history, making sure all these other axes are kind of covered. And I actually know this person who's writing all these comments, and I want to say a shout out to her, but she also pointed out no sodas with a capital N and O. And she's right, that the sodas can also have an adverse effect on bone health. So thank you, MH, you know who you are, for providing those comments. As far as other questions on bone, there was one other here, and it's interesting because I've been here in University of California, San Francisco, or Children's Hospital Oakland since 2006, and the question was, is scoliosis common for thalassemia due to osteoporosis? I haven't come across scoliosis at all, really, and what's the best way to treat it? But to answer the first question, I haven't seen it that often. Dr. Erkin-Cakmak, have you come across that in any of the literatures, if that was a common occurrence?
Yeah, it's very interesting. In my readings, also in preparation for this webinar, I also didn't come across scoliosis as one of the reported abnormalities or skeletal abnormalities in the literature. Definitely, we do not come across. And I don't think that there's a lot known about it in the literature. I didn't see it reported.
Yeah, and Dr. Feng was nice enough to also comment in the section, who's one of our amazing bone specialists, micronutrient specialists, zinc specialists here with our comprehensive thalassemia care team. And she's also done many studies looking at DEXAs in our thalassemia kids, and she has not come across scoliosis as a common occurrence. It's quite rare, though the abnormal vertebral height deficits are common. And that Yeah, and so that's something to again keep in mind in the overall health of the vertebral column, that the vertebral bodies can get affected in this particular condition. As far as, again, going along the bone theme right now, I guess we've kind of shifted over and we may have to have a whole nother seminar series on bone health in thalassemia. And so we were talking, one of the questions again, what are the things we can do to improve bone health in our thalassemic patients, and what ages are critical? So we kind of answered that, I think, already. And there's a question here. It was interesting to see that the chelation can affect bone health. Is there a chelation you recommend over another for that reason? Do you use more desferal or deferoprone? I'll ask you first, Dr. Erkin-Cakmak, what you would say to that.
Yeah, in my experience, I leave this decision to our hematology team, because the side of the tolerance and the administration of the chelation is also very important. And I did not, I don't pick one chelation over the other agent, but I think what is more important is to ensure good chelation, compliance to chelation during the teenage years, early childhood years. And it's very challenging with the rebellious years of adolescent. We know with all chronic disease, that's the time that everything goes very difficultly. And but trying to explain and encourage our teenagers to be compliant with their chelation, so we can actually improve the overall health for the adult years. And encouraging, I think, yes, as we all know, all medications have side effects or risks, but trying to leverage these side effects with the increased exercise, the increasing and optimizing the nutrition, and optimizing the transfusion regimens, offering the multivitamins along with the vitamin D and the trace elements to make up for any risk that comes with the chelation, but still keep the chelation regimen on board to support the overall protection from the iron toxicity is important.
I have an interesting question, and I believe a very good question here. Do you discuss fertility issues with your patients, especially in their teenage years? And have you considered fertility preservation?
That's an excellent question, and we definitely are lacking on bringing these issues into our conversations, and we have not sought fertility preservation for our patients. And I think the pros and cons should be also discussed when you think about the fertility preservation. For females, they need to be in puberty and they need to be ovulating, and you're thinking about the oocyte retrieval and freezing. And for males, you're thinking about the sperm collection and storage of sperms. They're all costly procedures, and I don't know if an insurance company would be supporting this. I would put my effort in getting the growth hormone covered by insurance rather than asking the insurance to cover fertility preservation for this patient population if I need to prioritize things, because I think with growth hormone supplementation, we have better targets, like improving the final adult height and potentially improving the bone health, because we know IGF-1 plays a huge role in bone accrual and bone structure. So that's how I think about your question. I don't know if it would be an answer.
I think it's a great point that you bring about the growth hormone, because I also want to again emphasize that growth hormone does a lot more than growth. I was talking with Dr. Erkin-Cakmak before the seminar started, and I feel sometimes, particularly when our population has aged out of the pediatric clinics and gone to adults, we tend to not think about growth hormone anymore. But the studies are out there to show that growth hormone deficient adults do have a significant impact on their quality of life if they're not having their growth hormone replaced, even though they're done growing. And we mentioned bone density, we mentioned end adult height, but what it does for lean muscle mass, what it does for focus, what it does for lipid levels, this is all documented. And it's even been shown to help with cardiac function in thalassemia patients who've had growth hormone deficiency, that the cardiac function would improve when you replace growth hormone, which makes physiologic sense. If you're missing something, it only makes sense that you replace it. So I guess as one of the things that I can try to, again, help emphasize to a lot of our practitioners out there around the world is that we continue to monitor for all these endocrinopathies, including growth hormone. I didn't see a question that came up about how to screen for it, but what I would, in what Dr. Erkin-Cakmak already said, is it doesn't necessarily have to be a growth hormone stimulation test, but perhaps the IGF-1 levels, along with an IGF-BP3, can be at least a screen to think about that this individual may have growth hormone deficiency as an adult. Certainly we're doing it in the kids, but I think and encourage everybody to continue to look for these things in adulthood. There is a question here about transfusions. Are there any therapies that can substitute or replace the need for transfusion? I guess other than a bone marrow transplant, I'm not quite sure, at least temporarily or in the short term. That might be a better answer for a question for the hematologist to answer. And on that note, I should really thank my mentors, Dr. Elliot Vichinsky and Dr. Ash Lau, for really introducing me to an amazing population to care for when I joined Children's Hospital Oakland in 2006. I didn't give my background. I'm half Pakistani, half Filipino. I jokingly call myself Pakapino. But being Pakistani, I actually have family members with thalassemia in Pakistan. And I still remember meeting one of my family members who had thalassemia in the 80s. I'm dating myself, but it was in the 80s. And unfortunately, they didn't make it. The next one to have thalassemia was just recently in the last 5 years, and fortunately they're doing well. And perhaps this serves as a story to serve as a good close to and a testament to the wonderful advances hematologists have done for our thalassemia population to increase the longevity and lifespan, so that the length of life and what we see with kids who are born with thalassemia is actually much brighter and having a longer life. And now I'm hoping, along with Dr. Ayca Erkin-Cakmak and the many providers here on this call, that we can now improve the quality of life for this group of people who are living longer. And to do so will require more research and more potential interventions, and to be brave about thinking about modalities, whether it's growth hormone use in adults or, as mentioned before, denosumab or permethrinate or bisphosphonate therapy, to overall improve the quality of life. Since it is the top of the hour, I'm going to give my concluding remarks and thank again Dr. Erkin-Cakmak for really shining a spotlight on this topic that is so important to our patients with thalassemia and to the providers on this call. We also want to thank our colleagues at the CDC's Division of Blood Disorders for this invitation and opportunity to be with you today, as well as Craig Butler and the Cooleysanemia Foundation for hosting this webinar. So shortly, you'll receive an email asking for your feedback. So please respond with your comments. If you have any additional questions about today's presentation, please contact Cynthia Sayers at C as in cat Sayers, SAYERS, at cdc.gov. This webinar will be archived and the content will soon be available at CDC's Division of Blood Disorders website, shown on this slide. Thank you everyone for joining us. I hope you have the great rest of the day wherever you may be. Thank you.